Good morning, everybody. Welcome to Cairo and welcome to the Mediterranean Society of Otology and Audiology 2024. I will give just a brief idea about the Eustachian tube and Tympanoplasty, and then our second speakers will talk about the Tuboplasty. So to understand the Eustachian tube, we need to know that it has, of course, two parts. The fibrocartilaginous Eustachian tube, it's part of a whole system of contiguous organs, which are the nose, the palate, the nasopharynx, and the middle ear cleft. With the middle ear cleft, of course, consisting of the tympanic cavity, which includes the bony Eustachian tube and the protympanum, and the mastoid gas cell system. And the tympanic cavity and the mastoid gas cells are interconnected, and they allow the gas exchange and pressure regulation inside the middle ear. So the fibrocartilaginous Eustachian tube is not just a simple tube, it's a dynamic conduit with its mucosa, its cartilage, its surrounding soft tissues, its peritubal muscles, the superior bony support, and it has a very essential role in optimizing the middle ear sound transmission. This we all know very well, but it also has a very important role in protection of the middle and inner ear structures. So it is indispensable in maintaining the balance of pressure variations within the middle ear cleft. It has a mechanical protection role against nasopharyngeal secretions and pathogenic microorganism reflux from the nasopharynx, of course, and against retrograde propagation of vocal sounds. It has a local immune defense system, and its mucociliary clearance of secretions from the middle ear into the nasopharynx. So as we all know that ventilation is the key. Any problem with the Eustachian tube, we have problems in the middle ear. So we will see how we should address these, but the middle ear ventilation is controlled through the Eustachian tube function, through a pressure buffer mechanism, which is produced by the middle ear and the mastoid bone, and through transmucosal gas exchange in the tympanic cavity. The mastoid buffer, which is very important, and according to Boyle's law, at a constant temperature, pressure multiplied by volume equals a constant, which means that we have two very important items, the pressure and the volume. If any one changes, the other one has to inversely change. And since the volume does not change very much, because this is the volume of the mastoid of the patient, so it will cause a variation in the pressure. So applied to the mastoid bone, this will mean that if we have a smaller mastoid volume, this will tend to cause a greater change in pressure. The smaller mastoid bone, of course, volume will come from either something pathological or sometimes from a genetic or from a constitutional formation. So the mastoid air volume will dilute the pressure changes in relation to its size. The larger the mastoid, the mastoid air system, the more dilution of pressure changes. It can absorb or it can deal with more pressure changes, which means that when we have a smaller mastoid, this is more vulnerable to pressure changes, and it can develop a compensatory buffering mechanism, such as an additional tympanic membrane retraction or a middle ear volume reduction by fluid accumulation. This is to keep the pressure and the volume constant within their relation. And this was very well explained by Jacob Sadeh and Udi in 2003, when they described the mastoid and tympanic membrane as pressure buffers. We also have the interattico-tympanic diaphragm, which divides the middle ear into two compartments. An antoinferior compartment, which is responsible of the mucociliary clearance, and any failure in this compartment will lead to stagnation of the fluid and a secondary bacterial infection. And we also have a posterosuperior compartment, and this one is responsible more for the gas exchange function, and any failure in this compartment will lead to a retraction pocket. Both these compartments, the anteroinferior and the posterosuperior, communicate through the anterior and posterior tympanic isthmi, and of course we can have any obstruction on this of the tympanic isthmus, like mucosal fold variations, inflammatory webs, retracted tympanic membrane, diseased attic mucosa, or a cholesteatoma. And this is a picture that I borrowed from Ars and Dix. And we can see, number one, the, okay, so it doesn't work, okay. So we can see the head of the malleus, the body of the incus, the stapes, and in front of them we see the anterior tympanic isthmus, and number 5, we can see this is the posterior tympanic isthmus. So the Eustachian tube function, as we said, it has a dynamic function. It opens like a dilatation wave, and it works like a bellows, like in the picture, to insufflate air, and around 1 to 2 cubic millimeters of air with every swallowing act. Okay. And as we of course know, the effect of the muscles on the Eustachian tube, contraction of the levator veli will lift the cartilage medially, contraction of the tensor veli will lift it or maintain it laterally, propagation, then there is propagation of the opening towards the isthmus, and there is opening of the valve. So any inspection with an endoscope is very essential before doing any middle ear surgery, just to know the opening of the Eustachian tube, is it correct or not? And we can also examine the movement of the tympanic membrane during a Valsalva maneuver. And a tubal dysfunction, of course, is a very important cause of a chronic otitis. And if we do not address the Eustachian tube when there is a tubal dysfunction, we risk of having a relapse of the disease. And we might also face a patulous Eustachian tube with autophony, hearing of our own breathing, echo-like vocalizations, and this is usually caused by hormonal changes, rapid weight loss, or chronic middle ear dysfunction. So a preoperative assessment and evaluation of the Eustachian tube is very essential, and failures of surgery are usually associated with an Eustachian tube dysfunction. So before performing a tympanoplasty, we need to thoroughly assess the Eustachian tube and any pre-existing issues with the Eustachian tube. And we can do that by a tympanometry or endoscopy, or we can do a CT, a Valsalva computed tomography, better with the patient standing up. So this is where we can use a cone beam CT. So the nasopharynx has to be checked, and we might find that we have an obstructive or a functional pathology. Or intraoperatively, we need to check, of course, the protympanum endoscopically to see if anything is obstructing the Eustachian tube. Obstructive pathology like an infection, adenoids, sometimes even in adults, rhinitis with effusion, allergy, mechanical like an important septal deviation, and Eustachian tube polyp or just close to it, nasopharyngeal tumors, or a laryngopharyngeal reflux. Or we might have a functional pathology where the muscles are not functioning at all, and we have an inadequate reflex of tubal muscles after stimulation by pressure gradient between the ear and the nasopharynx. Or we might have a mixed pathology. So Poe and Kujawski have, this is their Eustachian tube dysfunction score, VMLT, which is the valve, the mucosa, and the levator veli and the tensor veli. And they give a score for each condition. Or you can also have, or we can use the Eustachian tube dysfunction questionnaire, which has 7 items and a score of 7 for each, and it will give us an idea about the problem. So how do we manage rapidly the obstructive pathology? Saline wash, blowing of the nose each evening, a mild, not forceful Valsalva, anti-allergic, nasal corticotherapy, pharyngeal disinfection, corticosteroids and aminoglycoside spray, antacid, septoplasty, adenoidectomy, or the tympanostomy tube, of course, depending on the pathology I have. But a functional pathology, we can resort to an active physiotherapy, which is almost the same as the obstructive, but we can also use muscle development exercises for the soft palate, the tube, and the tongue. Or we can have a passive physiotherapy.
Dear doctor, your time is up.
Or we can resort to a passive physiotherapy, like the use of autovent, a monosonic nebulizer, or sometimes the tympanostomy tubes, which improve the middle ear mucosa, but they cancel the pressure difference, of course. Failures of treatment, like in bad compliance, if I have a patulous Eustachian tube, persistent obstructive pathology, active or inactive mucosal pathology, and in this case, we will need to resort to a laser tuboplasty or a balloon tuboplasty. This is an algorithm which was described by Tarabishi and Kapadia, which will show in almost every case what we need to do. Where is the disease? Is it segmental? Is it generalized? What will I find on the CT? What will I see when I inspect the tympanic isthmus intraoperatively? And the ways of dealing with each one. And as a conclusion, each chronic otitis needs an endoscopic nasopharyngeal check, obstructive or functional pathology. Why I might find one of both or both together. And I should propose a specific tubal therapy to help success of ear surgery. Thank you.
Thank you, Dr. Sherif, for your presentation, giving us quite an overview about the function of this Eustachian tube. I think we'll take the questions by the end of the session. Our next speaker, Nuri Ozgirgin, Eustachian tube and balloon tuboplasty. Did I say Ozgirgin right or wrong? Okay, thank you. Eustachian tube and balloon tuboplasty. Please, sir.
Thank you, Mr. Chairman. I'm very much honored being in this distinguished session, and I'm going to talk on the Eustachian tube and the balloon tuboplasty. The Eustachian problem has two main concerns. One is dysfunction, and this is the other is the patent tube. And you can see the nasopharyngeal photographs of these two different situations. The valve is very much important. We know that the mastoid cells has direct connection with middle ear, and there is an isthmus in between the osseous and cartilaginous part. This is the critical part, but the most critical part is, of course, the cartilaginous part. And these are the resting and active openings of the Eustachian tube nasopharyngeal orifice. When we talk on the Eustachian tube dysfunction, you can easily observe that the cartilaginous portion is the most important issue, and this is cartilaginous portion is included in every aspect of Eustachian dysfunction. So we have to focus ourselves on the cartilaginous part of it. The tympanic membrane, of course, can show the serious status of the Eustachian tube. And we can, even it is not very very often used, rarely owned device, the tubomanometry can give us information about the function of the Eustachian tube, even if the tympanic membrane is perforated. And when we go through the anatomy of the Eustachian tube, of course, that is close to tympanic orifice, and sometimes the bony wall of the Eustachian tube may be dehiscent when being opening to the osseous canal of the Eustachian tube. So this can be a serious condition that may give complications with the surgery. What has been done until now? It was Eustachian tube tuboplasty by the middle fossa approach in 1966 by William House. We always have been the witness of recurrent ventilation tube insertions in this problem. There has been approaches for the osseous part. Laser applications has been the method of issue, but of course, internal carotid artery was the kind of critical point, and the bone fractures of the internal carotid injury has been developed with the balloon dilatation of both sides parts of the Eustachian tube. There have been some laser applications. This doesn't belong to me, but to Dennis Poe. And it was the 1980s when Dennis has shared his opinion by applying lasers for the orifice of the nasopharyngeal orifice of the Eustachian tube. And 1 year later, following the laser surgery of what Dennis Poe procedures, you can see the photographs of the nasopharynx. Then, again, Dennis Poe and friends has been proceeded with the microdebrider tuboplasty, but the success was only 70%. And then with Holger Sudov, the balloon Eustachian tube tuboplasty has been introduced. I will show details. These are the devices that we use for this balloon tuboplasty. Introducers and the balloon and the pump. This is the balloon details that comes from the probe. This is about 2 centimeters. That means that can go until the isthmus, until the osseous part. And when blown with water, it comes to the Eustachian tube cartilaginous portion, and with a 10 bar pressure for 2 minutes, the cartilaginous part is dilated. Here are some I'm showing 3 of them being prepared for this procedure. Again, and then after being finished with this preparation, this is the BFS balloon that has been introduced by Holger. The probe is introduced into the orifice, not very long, and then the balloon is introduced through it towards the osseous part of the Eustachian tube to be placed there for 2 minutes with 10 bar pressure. And there has been the Acclarent balloon, which received the FDA approval maybe 10 years ago, and this is being applied in US now, only in US. I was one of the first to also experience with the Acclarent. There maybe have 2 questions coming out with bilateral catheterization and endoscopic sinus surgery and tympanoplasty. I can generally perform within the same session. We have to avoid mucosal laceration. Again, I mentioned I generally perform the same session, tympanoplasty. I have 112 cases with tuberculosis, and some advices for experience. We need to perform a good decongestion. The turbinates should be lateralized if necessary. Bleeding control is important. Angle of the guide is important. Sometimes the position of the orifice may be different. This is a controversy, whether it is being applicable or no in children. I think Professor Bachman will talk on this. The complications are minor generally. Minimal bleeding and mucosal laceration is the most common one. And the 2 years after success is about 85%. And this is the end of my talk, to be in time. Thank you very much for your attention. And finally, I wish to invite you all to our first Istanbul meeting in 2026.
Thank you for your presentation. And as I said before, we're going to keep the questions by the end of this session. Our next speaker is Caglar Batman, Eustachian Tuboplasty.
By the way, it is very easy for me to now make my presentation because Professor Nuri Ozgirgin has described everything well. I'm going to talk about pediatric Eustachian tuboplasty. So I'm going to pass this this first slides because it has been told before. Let me talk about a brief information about Eustachian insufficiency. It is produced by adenoid hypertrophy, nasopharyngeal masses and tumors, sinusitis predominantly, sphenoid sinus, pediatric sinusitis, nasopharyngeal fibrosis and fibrotic bands, which we had a video about that, and some neuromuscular problems, and also cranio-maxillofacial abnormalities. So, as a result of Eustachian insufficiency, there's going to be middle ear aeration problems, barotrauma, otitis media with effusion, recurrent otitis, acute otitis media, subacute otitis, epitympanic retraction and retraction pockets, adhesive otitis media, chronic otitis media, and cholesteatoma. So, Eustachian tube is of great importance in maintaining the aeration of the middle ear and many ear problems, as you know. So indications are the same as in adults. Middle ear aeration problems, biotrauma, otitis media with effusion, and these are the same. So I'm not going to talk about that preoperative evaluation because my colleague Ozgirgin has told it about them very well. Let me show you some slides, some videos about tuboplasty with adenoid hypertrophy. You see, adenoid tissue is too big, and even you couldn't enter the Eustachian tube in case of adenoid tissue. So what we had to do is first we have to remove that adenoid tissue, as you see, and then enter the Eustachian tube safely. And once we enter the Eustachian tube, I'm just controlling with endoscopy, controlling the eardrum and seeing if this tuboplasty is efficient or not. Now we are inflating the balloon, and you see the tympanic membrane is getting inflated. So you see the inflation, and once we remove the tube, it goes back. You see the tip of the tube here, and it's very pathognomonic for a good Eustachian tube dilatation in children. And another problem is some nasopharyngeal fibrosis and synesthesia. And as you see in this video, let me start it. There's some most probably adenoidectomy before, and you see we did the tuboplasty, and you see here there's a synesthesia. And in the synesthesia, we have to remove it because it prevents the pumping of the air into the Eustachian tube. So we have some contraindications, craniomaxillofacial anomalies. It's important because in most of them, Eustachian tube is very patent. Cleft palate, either complete or incomplete, and children under 3 years old. This is a relative contraindication because we need a good vision for Eustachian tuboplasty through the nose. I have 2 publications about that. These are preliminary publications. One is the efficacy of Eustachian balloon tuboplasty as a first-line treatment in otitis media with effusion in children. And this is a study that we compare tube insertion and tuboplasty, and with the same group, we did the study of quality of life in children with Eustachian tube dysfunction with tuboplasty. And in our material and method, we have 62 patients with 115 years, and 30 patients with balloon tuboplasty, 32 patients with ventilation tube insertion. And this is the criteria for measuring quality of life. We use OM6 survey for quality of life. So in our study, we have seen that preoperative airborne gap in tuboplasty is 27.6 dB, whereas post-op is 9.6, and you see the airborne gap also in ventilation tube insertion. So, as a result, follow-up after 13 months postoperatively, 10 Eustachian tuboplasty patients have type A tympanogram, and 18 ventilation tube patients have type C, 6 ventilation tube have type A, and 8 ventilation tube still ventilation tube is present. So in our criteria, which we search for the quality of life, improved in both groups. So they are the same, whereas improvement is faster with tuboplasty. So as a result, Eustachian tuboplasty is at least as effective as ventilation tubes as a first-line treatment. It must be combined with adenoidectomy in the presence of adenoid vegetation. It is possible to protect from some of complications of ventilation tubes by using tuboplasty as a primary treatment. So it is clear that balloon tuboplasty, both child's and family's quality of life is improving more faster. In tuboplasty, ear protection is not necessary as in ventilation tube insertion. Moreover, tuboplasty is mandatory if enough treatment is not achieved by ventilation tube insertion. Thank you very much for your attention.